And we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare and community wellness. We are continuously growing, learning and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa. And we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa. And we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable
So, ma'am, it's 3, 2, 1. Over to you, ma'am.
Good evening to all. I am Dr. Kumar Mandavkar on behalf of JB Pharma. Welcome you all for the tonight's Lead HF session 3. It's a privilege that we have all the esteemed cardiologist and nephrologist Indian expert faculties today with us who are going to share their expert views on the topic of choosing guideline-directed medical therapy in heart failure in context of CKD. So to begin with the agenda of the meeting, first there is a context setting by our esteemed moderator, Dr. Satish K. Sir, for first 5 minutes, followed by Dr. Shashi Kumar Sir, a renowned nephrologist, will share his presentations for 15 minutes, and then there will be a cardio-nephro crosstalk expert panel discussions, requesting you all to please share your questions during the meeting. So it's a privilege to introduce our today's faculties, our esteemed moderator, Dr. Satish K. Sir. He is from Bengaluru, Magnus Diagnostic Center, a renowned cardiologist. We have our speaker, Dr. Shashi Kumar Sir, a renowned nephrologist, director and HOD of Nephrosciences, Paras HMRI Hospital, Patna. On expert panel, we have Dr. N.C. Ambekar Sir. Sir is a senior nephrologist, BJ Medical College, Sassoon Hospital, Pune. We have Dr. Sunil George Sir, a renowned nephrologist, associate professor HOD nephrology from MES Medical College, Kerala. We have Dr. Vikas Agarwal Sir, a senior consultant interventional cardiologist, professor, Department of Cardiology, BHU Varanasi. And we have Dr. Anup Agarwal Sir, a senior consultant cardiologist, clinical director, structural heart disease care hospitals, Hyderabad. Welcome all the esteemed faculties for the tonight's this meeting. And now I request our press moderator, Dr. Satish K. Sir, to please start the meeting. Sir, please.
Yeah. Good evening, everybody. I am Dr. Satish K. Just a small correction. Like I am professor and head of unit at Jaidev Institute of Cardiology, Bangalore. Uh, so you put up like visiting. I'm a visiting consultant at the diagnostic center, but I'm professor and head of unit. Other than that, thank you, JB Pharma. Thanks, Dr. Komal, everyone, for inviting me as a moderator. Like among senior cardiologists and nephrologists here, it's an honor and privilege. So without much ado, we'll move into the thing. As you said, there is a crosstalk now between cardiologist and nephrologist. Similarly, there is a crosstalk between kidney and the heart. So both are interrelated. Like kidney failure will lead to heart failure will lead to kidney failure. We have cardiorenal and renal-cardiac syndromes as well. And many diseases affect kidney and heart together. Say diabetes, hypertension, atherosclerosis. There are common risk factors for both of them. And the problem with managing heart failure in kidney failure is like the dosing, medications, adverse events, risk of hyperkalemia, drug interactions. So most of these things are very complicated for an individual specialist to manage. So there has to be a crosstalk between cardiologist and nephrologist when we are managing heart failure and kidney failure, especially in someone who has very severe renal disease, where the risk of hyperkalemia is too much. And whether these RNAs, we very well know RNAs are cardioprotective, but at the same time, whether they are renoprotective, there is still debate. And like we'll have a lot of discussion on this today with the eminent cardiologist and nephrologist on the panel being here. So without much ado, like we'll proceed with the speaker, Dr. Shashi Kumar, for his talk. Thank you.
Thank you, sir. And thank you, JB Pharma. Thank you, Dr. Komal, for providing me this platform to talk on a very important topic, which is quite commonly seen in our day-to-day hospital setup. So just bear with me for a few seconds so that I can share my slides. And can you let me know whether my slides are visible or not? My slides are visible now?
Yes, sir. Yes.
It's full screen? Yeah. So again, welcoming all the delegates. We have our illuminated moderator and panelist. So today we are going to discuss choosing goal-directed medical therapy in heart failure in context to chronic kidney disease. As Dr. has just mentioned, that this heart failure is very common among chronic kidney disease patients, especially when once your the CKD advances in higher stages, stage 4 and stage 5, they have concomitant cardiological disease, they have heart failure, and many a times this heart failure condition is underreported just because the symptoms of heart failure as well as the CKD may overlap each other. So many a times we may not diagnose heart failure in CKD population, and that's why this condition of heart failure is quite underreported in CKD population. Now, so what we can do for our patients? When we look at the literature, the incidence of heart failure is quite common. And as just Dr. Satish has just mentioned that this heart and kidneys are intimately, they are talking to each other, they have crosstalk, they are intimately linked. So we have cardiorenal syndromes. We all know they are further categorized in 5 classes. The first 2 classes is cardiorenal syndrome. The next 2, class 3 and class 4, is renal-cardiac syndrome, and the 5th is a disease involving both cardiac and renal disorder. So from ages we know the condition of heart can deteriorate your renal function, and the condition of kidney can deteriorate your heart function. So why this is a lethal combination? So when we look at the literature, the prevalence of kidney dysfunction in heart failure is almost 50 to 60%. And more than 40% of heart failure patients have chronic kidney disease. And this close relationship between chronic kidney disease and heart failure worsens their prognosis. Because when the patient have heart failure and kidney dysfunction, they not only progresses the condition of each other, but they have multiple comorbidity as well, like fatigability, inactivity, malnutrition, inflammation, catabolic action, and muscle loss. So because of this, they have exercise intolerance and lots of other problems. So this is the lethal combo when a patient have both chronic kidney disease and chronic heart failure. And it has been seen that heart failure has a wide clinical implication, including the potential for kidney damage. How they damage the kidney. First of all, how we define heart failure. Basically, it's a condition where heart cannot meet metabolic requirements and unable to accommodate systemic venous return. And in return, what happens? There is a RAS activation, there is sodium and water retention, there is vasoconstriction, and we have few compensatory mechanisms to restore this cardiac output, like increased venous pressure, there is increased sympathetic nervous stimulation, and there is increased natriuresis. And that led to worsening your kidney failure that may be because of hypoperfusion, apoptosis, and fibrosis. So there is a vicious cycle. With worsening heart failure, they impact the renal function, and the worsening kidney failure is again worsening the heart failure condition. And that's here a role of nephrologist and cardiologist came to break this vicious cycle. So what we can do for our patient, in my next few slides, I'm going to share a few literature and the management. Now, this is a very important slides. Look, these are the hypothetical slope, the curve of a CKD patients. So on an average, we can expect a CKD population is decreasing their GFR by 10 milliliter per minute per decade. So this blue line is the usual CKD slope. And if we manage well, that patients may not achieve the stage of end-stage renal disease. This light pink is stage of end stage, where GFR is too low and patient's kidney needs support in the form of renal transplantation or hemodialysis. On top of that, if patient has heart failure and look at this hypothetical curve where there is an increased rate of progression, and what I was saying that it's 10 ml per minute per decade, it increases to 20 to 30 milliliter per minute per decade, and that makes patients susceptible to go into stage of end stage where the requirement of dialysis or transplant is inevitable. So that's the reason why the combo of heart failure and chronic kidney disease is quite deleterious. Now, when we look at this study, which was published in 2018, and they compare the all-cause mortality and cardiovascular disease-specific mortality in patients with heart failure. When they did the subgroup analysis, look at the curve. This blue curve is for heart failure only. This magenta color curve is for type 2 diabetes with chronic kidney disease. This green color is patients with CKD and heart failure. And the lower one is patients with type 2 diabetes, chronic kidney disease, and heart failure. And look at the cumulative survival. It's worse if patient is having chronic kidney disease and heart failure. Similarly, when we compare this cardiovascular disease-specific mortality in patients with heart failure, look at the lowest curve, that is the patients with type 2 diabetes, CKD, and heart failure. And look at the separation. It is quite early in their feature. This is a long-term study. Almost the population is studied to 10 to 15 years. And look at the separation of curve. They are quite early. Now, coming to pathomechanism. So both the conditions, chronic kidney disease as well as heart failure, can exacerbate the conditions of each other. How a heart failure can worsen CKD and how a chronic kidney disease or even AKI can increase the heart failure instances is beautifully depicted in this cartoon. So by virtue of atherosclerosis, increased risk of diabetes, arterial hypertension, wasting in cachexia can lead to increased progression of chronic kidney disease. And on the other hand, increased incidence of anemia, low hemoglobin, low iron, low erythropoietin, hyperphosphatemia, increased PTH, increased FGF23 can all lead to increased cardiac hypertrophy, increased fibrosis that lead to failure. So there is a complex interaction between the mechanism of heart and kidney that led to this cardiorenal syndrome. Now, when we look at the therapeutic strategies in heart failure, we all know the 5 pillars of therapeutic strategies in heart failure. The most commonly used these 5 pillars include the SGLT2 inhibitors, ACE inhibitors or ARBs, mineralocorticoid receptor antagonist, ARNI, and beta blocker. So this graph shows, this cartoon shows the relative how they act on the heart and kidney. So SGLT2 inhibitor, we all know it's a very good drug. Recently discovered, almost 7-8 years has been passed. And how they do, basically they decrease the proximal tubular hyperreabsorption of glucose and sodium. And by that, they vasodilate, they vasoconstrict your afferent arteriole. And initially they decrease the GFR, but later we can flatten the curve of CKD slope. Similarly, we have ACE inhibitors, and we all know it acts on the efferent arteriole by vasoconstriction. They prevent the vasoconstriction of efferent arteriole and lead to systemic and glomerular hypertension. We have mineralocorticoid receptor antagonists. They inhibit aldosterone-mediated effects like mesangial cell proliferation, podocyte injury, sclerotic changes, and arteriolar hyalinosis, and aldosterone escape. Beta blocker. They basically inhibit the alpha and alpha-adrenergic mediated afferent arteriole vasoconstriction. They act on beta-adrenergic mediated renin release also. And we have ARNI. So today the talk of the molecule is ARNI, which the ARNI is basically a composition of two things. One is aldosterone receptor blocker, that is Valsartan, and another is neprilysin inhibitor, that is Sacubitril. So it's a combination of Sacubitril and Valsartan, and it inhibits the degradation of nitrotropes that through CGMP generation mediates decreased sympathetic nervous stimulation, decreased afferent arterial vasodilatation, leading to increased GFR, decreases plasma volume, and decreases potassium relaxing contractile mesangial cells. So these are the 5 pillars of therapeutic strategies in heart failure, which come handy to our patients. Now, where can we use these molecules if patient has chronic kidney disease? So if GFR is more than 60, we can use any number of molecules at any place depending upon the patient's conditions. And many a times we use almost 4 or almost all 5 drugs simultaneously. But once GFR is below a certain level, we have some restrictions. We cannot use 1 or 2 or 3 molecules. So here is a comparison of various therapeutic strategies like RAS blockade, beta blockers, mineralocorticoid receptor antagonists, ARNI and SGLT inhibitors. Apart from that, we have other molecules like ibabradine and other molecules also to use in heart failure patients. So if GFR is more than 60, nothing to worry about. Even 30 to 60, we can use all the molecules. But once your GFR goes below 30, especially for ACE inhibitors, ARNI and MRAs, we have some restrictions. We need to monitor your serum potassium. We need to monitor eGFR, and also how can we modify the doses, and when should we stop which drug. I would let you know in my next few slides. So what are the problem of managing heart failure in CKD population? The triple famine, which we'll discuss in our discussion also, the hypotension, hyperkalemia, and renal impairment. Not only renal impairment, but the worsening of renal failure is again a very important factor which we need to consider while treating our heart failure patients with chronic kidney disease. So this hypotension, hyperkalemia, and renal impairment results in treatment dose lowered, medication discontinued, but they don't tend to be very goes very well with our patients. So here is a chart showing which drug we can use at what GFR. So as I mentioned, if GFR is more than 60, we can initiate with cortical therapy. If eGFR is between 30 to 60, we can initiate with triple therapy that includes your beta blocker, SGLT inhibitors, and ARNIs. But these SGLT inhibitors are not indicated till date for GFR of less than 30. We have some studies in pipeline where we are using this molecule in ESRD population as well, not for glycemic benefit, but for cardiovascular benefit. But till now, we have recommendations till 20 ml of GFR. If GFR is below 15 to 30, we can start with triple therapy that includes your beta blocker, SGLT inhibitors, and ACE inhibitors. But again, we need to monitor serum potassium and eGFR. But if your GFR is less than 15, or if patient is dialysis dependent, we can continue with beta blocker. If patient is already on SGLT2 inhibitors, we can continue, and other molecules like isosorbide nitrate. Now, when to titrate? What we need to monitor is systolic blood pressure, GFR, and potassium. So if your increase in serum creatinine is by less than 50%, if your potassium level is less than 5.5 milliequivalent per liter, and there is no symptomatic hypotension, we can titrate ARNI or ACE inhibitors to maximal dose. But if any of the things occurs, like if rise in serum creatinine is more than 50%, if your GFR serum potassium is going beyond 5.5, we need to assess for any other cause leading to this condition, or we need to decrease the dose or stop the medication. If your heart rate is more than 60, then we can again titrate the beta blockers to maximal dose. But if heart rate is less than 60, we need to decrease or stop the beta blockers. My cardiologist friend will highlight on these things. Now, how this neprilysin inhibitors acts? As I mentioned, they are nitro peptide inhibitors. So by blocking the destruction of this natriuretic peptide, they increase the nitrolysis and diuresis and decreases the renin secretion. By virtue of this vasodilatation, they cause decreased blood pressure and increase endothelial permeability. They decreases the hypertrophy and decreases the fibrosis and decrease the sympathetic outflow. So most of the mechanism which led to heart failure is well covered by this neprilysin inhibitor. Now, we as a nephrologist, not we, but the cardiologist also, general physician also, is quite worried about using this ARNI in heart failure patients, because one of the components is Valsartan, and we are always worried about the worsening renal failure or incidence of hyperkalemia. So on this platform, I must say to all the listeners that worsening renal failure is not a cause of worry. What we need to do is we need to decongest the patient. Even at the cost of worsening renal failure, if we act on the hemodynamics of glomerulus, if we can decongest the patient, it will ultimately going to help the patient. And that is proven by different trials, right from Paradigm HF trial to Paraglide. And they all suggest a central role for the cardiac benefits of Sacubitril, Valsartan in nephroprotection. So when we do the sub-analysis of post-Paradigm HF heart failure study, look at the risk of hyperkalemia. We always worried about the risk of hyperkalemia, but look at this graph. The orange color bar line is those patients who are on MRA, that is mineralocorticoid receptor antagonist with enalapril, and this blue color bar line is those patients who have mineralocorticoid receptor antagonist with Sacubitril and Valsartan, that is ARNI. And look at the incidence of hyperkalemia. It's significant decreased incidence of hyperkalemia, especially the severe hyperkalemia that led to your treatment stoppage is quite lower in those patients who are receiving Sacubitril Valsartan on top of MRAs. Similarly, when we compare this enalapril with ARNI, with the presence or in the absence of mineralocorticoid receptor antagonist, the risk of significant hyperkalemia is quite low in those patients who are receiving this ARNI as compared to those patients who are receiving enalapril alone. And when we talk about the renal effects and associated outcomes during angiotensin-neprilysin inhibition in heart failure, the inclusion criteria for this study, which was published in Journal of American College of Cardiology in 2018, they compared the enalapril, Sacubitril, Valsartan, and what they conclude that compared with enalapril, Sacubitril, Valsartan led to a slower rate of decrease in GFR and improved cardiovascular outcomes even in patients with chronic kidney disease. So this blue line is with Sacubitril, Valsartan, that is ARNI, as compared to this black line with enalapril, and look at the preservation of GFR in the two groups. And even we compare the urinary albumin creatinine ratio, this is quite significantly preserved or decreased risk of increased USER in those patients who are receiving this ARNI as compared to those patients who are receiving enalapril alone. So when we compare head to head with ACE inhibitor versus ARNI scores over better preservation of eGFR as well as decrease in urinary albumin creatinine ratio. Now this chart is very important. What to do when there is a worsening of renal failure? So as I mentioned, if serum creatinine increases by less than 50% to a maximum of 2.5 milligram per deciliter, and if your maximum serum potassium is 5 or less than 5, nothing need to be done. In fact, we can up titrate the dose of ARNI and evaluate renal function and electrolytes. But if increase in serum creatinine is rise by 50 to 100% to up to maximum of 3.5 milligram, and if serum potassium touches 5.5 millimole per liter, then we need to evaluate the clinical status and other causes of worsening renal failure. And now in this condition, we need to consider halving the dose of ARNI and again re-evaluate for this GFR as well as for potassium. But if after starting this ARNI, if there is a doubling of serum creatinine and it going beyond 3.5 milligram per deciliter, and if your maximum serum potassium is more than 5.5, then we need to evaluate clinical status for other cause of worsening renal failure, and temporarily we need to consider for stopping this ARNI and again re-evaluate. Now, when we can re-challenge our patients with ARNI, seeing the robust benefit of ARNI on heart failure, we can re-challenge this molecule after 2 to 4 weeks, possibly with a lower dose after correcting whatever the modifiable factor is there. So after correcting the modifiable factors, we can re-challenge our patients with lower doses of ARNI after 2 to 4 weeks of stopping the drug. Now we have lots of study regarding the use of ARNI in renal outcomes across the spectrum of ejection fraction in heart failure. So here is a Paradigm HF and Paragon HF study. And when we look at this secondary outcome, that is kidney outcomes, what are those that are sustained decrease in eGFR by more than 50% and stage of end-stage kidney disease or renal death? So look at the hazard ratio, 0.56. So there is a 54% relative risk reduction with the use of Valsartan, with the use of this ARNI as compared to use of Valsartan or enalapril alone. And look at the separation of curve right from early days. The two curves separates regarding the proportion of patients who achieve this secondary kidney outcomes like eGFR more than 50% and end-stage kidney disease or renal death. And again, this ARNI slows decline in glomerular filtration rate when compared with enalapril or Valsartan. So look at the curve. This is the curve with ARNI as compared to the curve with Sacubitril or Valsartan alone. And when we compare the major adverse renal outcomes with ARNI versus enalapril or Valsartan, look at the hazard ratio of 0.56, meaning by there is 42% relative risk reduction with the use of ARNI as compared to Valsartan or enalapril. So end-stage renal disease occurred in 0.2% of patients with ARNI as compared to 0.4% with those patients who are receiving RAS inhibition alone. Now, when we compare the renal outcomes in Paraglide HF and Paragon HF trial, so look at the result. The ARNI reduces the risk of renal composite outcomes compared with Valsartan. The hazard ratio is 0.6. So 40% relative risk reduction with the use of Sacubitril Valsartan as compared to Valsartan alone. And the best part is the time to first nominal significance comes within the 2 months. So look at the early separation of curves as well as the nominal significance within the 2 months, where their outcomes are going in favor of ARNI as compared to Valsartan. Now, when we look at the individual component, so all the components, right from whether it's a 50% decline in GFR, whether it's a end stage renal disease, or whether it's a renal death, all favors ARNI. But this renal composite endpoint and 50% decline in eGFR is statistically significant, but stage of reaching end stage renal disease and renal death are non-significant. But numerically, this all data favors this ARNI as compared to Valsartan. And this is ARNI slows decline in eGFR. We already know this is upper curve is for Paragon HF trial and versus Paraglide HF trial. In both the studies, they have the different population, but ARNI scores over Valsartan in both the studies. So conclusion for this first part, that approximately 1 in 4 patients with HFrEF in Paradigm HF trial were classified as having at least high KDIGO risk of chronic kidney disease. Such patients experienced the highest risk of cardiovascular event, mortality, and had the worst health-related quality of life. The cardiovascular and kidney protective benefits and overall safety profile of ARNI relative to Valsartan remained consistent irrespective of KDIGO risk category, with no significant attenuation in efficacy at highest risk category. Taken together, the clinical benefits of Sacubitril Valsartan are consistent across the continuum of kidney risk and further supports consideration of ARNI even at the patients at higher or very high risk of kidney disease. Now, coming to the second part, and we'll discuss in brief the other molecules. And here is a systemic review on this cardiovascular benefits and safety of ARNI in end-stage kidney disease. So it's just recently published in KI reports, and what they conclude that this systemic review suggests that this ARNI benefits even end-stage kidney disease with HFrEF and MRF by improving left ventricular ejection fraction without increasing the risk of hyperkalemia, hypertension, or angioedema compared to standard care. And this study I was talking, it's still this KI report has recently published that they are quite helpful even in those patients who have end-stage renal disease. So especially in those patients who are on dialysis and having no urine output, the risk of hyperkalemia is lowest in those patients. So I can easily use this molecule in those patients. Now this is how the original molecule is better as compared to this generic, and they have fixed 1:1 molar ratio of Sacubitril and Valsartan. They have supramolecular complex with unique physiochemical properties. They have good solubility profile, enhanced viability of Valsartan, and higher dissolution rate at different pH. So that is the advantage of drug provided by JB Pharma, which is imported from innovator molecule. Now coming to other components of management of heart failure, I'll go in brief first with SGLT inhibitors, and we know the multiple ways this molecule can benefit both in heart failure and in chronic kidney disease and in cardiorenal syndrome. And I must say we are still evolving various other mechanisms through which this molecule can help our patients in cardiorenal syndrome. So we have a lot of study started with Credence, which took only diabetic kidney disease, but later DAPA CKD and EMPA CKD. This study is so good, so close to my heart, because they open a Pandora box so that I can use this molecule in my non-diabetic patient as well. So a diabetic drug was evaluated in a study population where non-diabetic patients numbers scores over diabetic patients. So this EMPA CKD study, they have 55% of patients population is non-diabetic. So that is the important. And both these studies shows the robust data regarding the use of this molecule even in non-diabetic patients. So this is a DAPA CKD study where almost 1/3 of population of this study is non-diabetic, and whether it's a primary composite outcome, secondary composite kidney outcomes, whether it's a composite cardiovascular outcomes or death from any cause, all the population has robust benefit those cohort who received this dapagliflozin as compared to placebo. Another molecule that is finerenone, this is non-steroidal mineralocorticoid receptor antagonist. We have two large studies, Fidelio DKD and Figaro DKD, and they involve almost 12 to 30,000 of patients. And look at their result. The median follow-up period is 2.5 years, and hazard ratio is 0.82. So there is a 18% relative risk reduction of primary composite endpoint, like kidney failure with more than 40% decrease in eGFR over 4 weeks period, or death from renal disease. And hazard ratio is 0.86, meaning by 14% relative risk reduction with secondary composite outcome like death from cardiovascular cause or hospitalization for any cause. And based on this two study, especially in patients with chronic kidney disease and type 2 diabetes, treatment with finerenone resulted in lower risk of CKD progression and cardiovascular events with placebo. They even decrease your urinary albumin creatinine ratio as well. And we know the correlation of urinary albumin creatinine ratio with your endothelial dysfunction leading to the various cardiovascular disease. So based upon this, there is a consensus statement from India on the renal benefits of ARNI, SGLT2 inhibitors, and bisoprolol in chronic kidney disease. And they said that this ARNI, SGLT2 inhibitors, and bisoprolol reduce the neurohormonal activity in several shared pathways and have enormous cardiorenal metabolic benefits across chronic kidney disease patients with or without concomitant heart failure, diabetes, and hypertension. This is published in JAPI, the Journal of Association of Physicians of India. And here are the relative indications where we can use this ARNI, SGLT2 inhibitors, and bisoprolol. We all know, I am not going to repeat this. We had seen in my previous slide. And here is the management of heart failure across the spectrum of chronic kidney disease. So patients with HFrEF with stage 3 or more of chronic kidney disease, meaning by ejection fraction less than 40%. So what we can do, we can give diuretics for decongestion, and we can start with quadruple therapy like ARNI plus beta blocker plus SGLT inhibitors plus mineralocorticoid receptor antagonist, and follow the heart failure clinical practice guidelines for device-based or class 2 recommendations. Now, those patients who have HFmrEF with CKD stage more than 3, meaning by ejection fraction between 40 to 50%, what we can offer to our patients apart from lifestyle therapy, blood pressure and lipid and glucose control, we can give diuretics for decongestion, we can add SGLT inhibitors, and even if patient is having heart failure, we can add ARNI, beta blocker, or mineralocorticoid receptor antagonist. But if patient is with heart failure with preserved ejection fraction, that is HFpEF patient with chronic kidney disease, CKD stage 3 or more, and ejection fraction more than or equal to 50%. Apart from diuretics, we can give SGLT inhibitors, plus we can consider for ARNI or MRS. Now, the take-home message for my talk, that combination of heart failure and CKD chronic kidney disease is common. Cardiorenal syndrome has worse prognosis. They not only increases the morbidity, economical burden, but the incidence of mortality is quite high. If GFR is more than 30, treatment is according to guideline. But if GFR is less than 30, there should be a collaboration of cardiologists and nephrologists. And with new potassium binders, we can use those molecules, which is quite worrisome in past. The trajectory of chronic kidney disease can be slowed down by RAS inhibition, ARNI, and use of SGLT2 inhibitor. CKD detection and treatment saves the heart. And this heart failure and CKD should never be treated alone, because there is a close connect between heart failure and CKD, chronic kidney disease, and this cardiorenal continuum should be treated as a whole. So that's all from my side. Thank you for your patience hearing. Over to you, moderator, sir.
Thanks a lot, sir. Now I request our esteemed moderator, Dr. Satish K. sir, from Jayadeva Hospital, the renowned cardiologist, to please start the panel discussion. Sir, please.
Yeah, it was wonderful discussion, very elaborate, Dr. Shashi. Congrats. Anyway, we'll move on to the next session, which is as equally important as this talk. Like we have few questions where we need a cross-talk between cardiologist and nephrologist on those things, which will be more practical. So can we move on to the question sessions?
Yes, sir. So we will take the questions from the panelists. So here is the first questions. We will start. Your opinion, sir, had showed that management of heart failure and some WAMI, they have showed that hypertension, hyperkalemia, and the management of this renal impairment. So how you are managing the creat levels or of the potassium levels, how you are starting GDMT in CKD. So we will start, sir, with Dr. N.C. Ambekar, sir, to share his views, and then we will move to Satish K, sir, and the cardiologist. Sir, please.
Good evening. Thank you. Am I audible?
Yes, sir. Yes.
Okay. Good evening, everybody. That's a wonderful lecture by Dr. Shashi Kumar. And thank you, Dr. Komal and Mr. Khare and Mr. Rathod for inviting me for this talk. I have a few interesting comments. Before I answer your question, when Dr. Shashi Kumar mentioned his second line, Dr. Mani had a very interesting comment when he was asked about to talk on cardiorenal syndrome. He said, if you have a patient of cardiorenal syndrome, send him to a nephrologist whom you don't like. Because you will understand that the prognosis of the condition is not very good, and you try to save the kidney, the heart gives trouble, and you try to save the heart, the kidney will get in trouble. Answering your question, I had an opportunity to discuss this issue with Dr. George Bakris. Unfortunately, all of you know that he died about 3 days back. What he was saying was that as you have to monitor the potassium and the creatinine whenever you start. When I asked this question to a couple of other nephrologists, what do you do? Do you start all the drugs at one time, or do you give them a gap? So Dr. Vijay Kher, whom all of you know, he's the senior most nephrologist in Delhi. He was saying that it is better to start one by one. Now, you start with, suppose, an SGLT2 inhibitor first or an ARNI first, and then you start with the other drug after some time. The reason being that sometimes the GFR can drop if you start both of them together. So you have to be a little careful. As far as your question was concerned about the potassium and the creatinine, I think that I agree with Dr. Shashi Kumar that you can give potassium binders, but they are very expensive, and it's not practical to give them because their taste is also, especially of calcium polystyrene resin, is tolerated very poorly. So coming back to the question, as you have to keep a watch, follow up these patients, and don't worry, because one of the senior persons had said that a rise of creatinine after giving any of these drugs is bound to happen. See, if a patient comes in acute decompensated heart failure, you will have to use a diuretic. Now, if he comes and the creatinine rises, which is our type 1 cardiorenal syndrome, even if it rises, one should not immediately worry too much. As long as the rise is less than 30%, it's okay. That is part of the thing. Only thing is when to start these drugs. Now, you could start an ARNI probably not immediately during the phase of acute decompensated heart failure, but start it later on and maybe give some gap in between the ARNI, SGLT2 inhibitor, and titrate the drugs according to the potassium and creatinine. But no need to suddenly get worried that the creatinine has gone up or the potassium, even if it is less than 5.5, that is good enough. As long, because what we are looking at is the long-term benefits of the drug, not at the short-term benefits. That's what I feel about this triple whammy, which you said right now.
Yeah, thanks a lot, sir. So now we will take the opinion of the cardiologist, all esteemed here. So Dr. Vikash Agarwal, sir, can you please share your views, and then we will take the moderator views, sir. Sir, please.
Yeah, good evening, and I think that was a wonderful lecture, wonderful talk. A lot of insights about how to manage these patients of heart failure. And now with the advancement in therapy in heart failure, now we have multiple drugs. And CKD does complicate matters once you're treating a patient of heart failure. And what the most important concerns are once you're using ARNI or hypotension and hyperkalemia. And once you add MRAs to these patients, again, the incidence of hyperkalemia even rises. So you have to be watchful in these patients. You have to take care of their potassium levels, their creatinine rise. And I think he gave us wonderful insights and wonderful charts about how to, what kind of creatinine rise should be alarming, and a small amount of, or a 30 to 50% creatinine rise should not warrant discontinuation of these drugs, but maybe decreasing the dose, or maybe continuing these drugs is warranted, which a lot of times physicians think, and they stop these drugs. So I think a bump in creatinine should not alarm, and as rightly said, patients should be continued on these drugs. And I think one of the most important things here is that in-hospital initiation of these drugs are now being recommended. I think we have enough data with ARNI use that in-hospital initiation in deserving candidates is important, because this is the time where you can monitor these patients. They are in hospital, you can monitor their potassium levels for a few days. And this is the time when you can guide these patients, teach these patients of heart failure how to go about their monitoring and how to do their follow-ups in the OPD. And this is the time when they are most receptive to how to manage their heart failure. So these are important treatment drugs that we have. All the 4 drugs that we have, ARNIs are important drugs nowadays. We have to use them carefully because of the hyperkalemia and hypotension. We have to keep a watch, but they do produce some remarkable effects in these patients, even in patients with renal dysfunction. So we have to use these drugs a bit cautiously, but all the patients of heart failure do deserve these drugs. Thank you.
Thanks, sir. So Dr. Satish, I'm requesting your expert moderator comment on this.
Yeah, it was wonderful listening to eminent nephrologist and cardiologist. Like Dr. Ambekar presented from his point of view. So Dr. Agarwal from my point of view, I being a cardiologist. So like both are right from our sides. Dr. Ambekar sir, like there is like now evidence that even in decompensated heart failures, we can initiate ARNIs even in ICU settings. Once in a while we do that. Like Dr. Agarwal suggested, like it's more easier because he is inpatient, we can monitor his potassium. And regarding this hyperkalemia, so hyperkalemia, whether in ICU setting or outpatient setting, like management will differ, definitely. So hyperkalemia in ICU setting, it's very easy for us to manage. So we can increase the diuretic dose, and we can stop mineral receptor antagonists, either in outpatient or inpatient. And we can give K binders. As Dr. Ambekar says, though it may not be very palatable, but that is the only option what we have. Like 2 days or 3 days, like potassium comes down significantly, and we may be able to reinitiate therapy in them. And in outpatient setting, what I usually do, like in our heart failure patients, most of them will be on combination of torsemide because it's longer acting than furosemide. But as we know, torsemide has some potassium sparing diuretic effect as well. So what I usually do is I switch them from torsemide to furosemide, so that like potassium is taken care of. And if still not better or potassium is still high, I cut down on the MRAs. Then think of down titrating ARNI. So this is my take on that. Like a difference of opinion is always welcome.
Okay. Thanks a lot. Now I request Dr. Sunil George sir from Kerala is the senior nephrologist. So the next questions about the dosage, how you are managing in your clinical practice about ARNI when you are initiating in such patients, how you are managing the doses, how you are uptitrating. So first we will take the nephrologist opinion and then we'll take cardio. Sir, please.
Yeah, thank you, ma'am. Before I start, I'd like to point out one thing, because we get a lot of consultations from cardiologists, like a CKD patient, 2, 3, creatinine of 3, 4. They come with an acute MI, and so they have to go ahead and do a angiogram or angioplasty. So many times we tell the patient that it's a contrast-induced nephropathy which can happen to you, and your creatinine, which is 4, can go up to 6, 7. You can become oliguric. You might require dialysis, etc., etc. But as a life-saving measure, we are forced to do a angiogram and an angioplasty. I've seen in a lot of patients, believe me, after the angiogram and the angioplasty, like instead of the creatinine going up, it is coming down. The creatinine, the very next day they recheck, the creatinine from 4 comes down to 3 and further lower down later. And they're discharged with a creatinine of 2, 2.5, etc. So I remember my cardiologist asking me, Dr. Sunil, are you sure this contrast, is it renoprotective or is it nephrotoxic? I tell him, no, it's because the cardiac functions have improved. And because of that, the renal functions are improving. And yeah, this is seen in many patients. I just want to highlight the importance of a good cardiac function, which can definitely improve the renal function. And one more word of, we nephrologists, we are a bit reluctant to start ARNIs, MRAs. I mean, it's most of the time it has been started by the cardiologist. And when it comes to a nephrologist, we'll be very cautious. We'll be very cautious of the potassium. We'll be very cautious of the rising creatinine, etc., etc. And our tendency is to bring down the dose of whatever it may be. Nephrologists, we are very comfortable using ARBs. We are very comfortable using SGLT2 inhibitors, etc., etc. But when it comes to MRA, like everyone is very fond of using finerenone, the Carandia molecule, as you all know. But then my couple of patients, they had very bad hyperkalemia. Here, I'm very happy to note that we nephrologists, we tend to write a lot of ARBs. I mean, we write a lot, left, right. And hyperkalemia is a risk for that also. But then I'd like to convey a message that we have seen in all the studies, when we combine it with an ARNI, the risk of hyperkalemia is less. So that is a very good point we have to keep in mind. And in those patients whom we write Valsartan, we should always, I mean, especially when there's associated cardiac failure or patients, diabetic patients, even if they don't have a cardiac problem now, in future also, they can definitely go into a cardiorenal or renocardiac syndrome. So it's always better to write ARNI. And you ask me about the dose, I'll start with the low dose, maybe 50. And then depending on the creatinine, the potassium, etc., we tend to step up the dose. So this is what we nephrologists, we feel.
Thanks, sir. And now we will take the opinion of our cardiologist, Dr. Anup Agarwal, sir, is here. So, sir, your opinion about using this drug, especially SGLT2 inhibitors, Dr. Shashi Kumar highlighted across the spectrum its use. What's your experience, sir? Can you please share your views?
So, SGLT2 inhibitors have basically become a cardiology drug now. It is no more an endocrinology drug, and it is a standard of care across all the spectrum of heart failure. In fact, it's the only drug which gets a class 1 recommendation across the entire spectrum of heart failure. So we are, I think the resistance of prescribing SGLT2 inhibitor is less and less now. We are almost universally prescribing in all our patients who have heart failure. As far as ARNI are concerned, and I think we have enough data now that we can't ignore this molecule over the traditional ACE inhibitor and ARBs. So when we have concomitant patient with CKD, I think SGLT2 inhibitor becomes a little bit more challenging because the efficacy goes down. So patients who have got GFR of less than 30, I don't even try. I know we can try, we can see how it goes and all that, but I personally don't use it. Same thing is with ARNI, but ARNI, I'm a little bit more liberal with that. But I'm not sure what my nephrologist's criteria would be, but I still stick to the GFR of 30. So when GFR is below 30, then I'm co-managing very closely with my nephrology colleagues. When the GFR is more than 30, then I'm quite comfortable initiating as well as up titrating these drugs. I see my patients more frequently in my OPDs, so I am very closely monitoring their potassium level, their rise in creatinine and all those things. But because here we are dealing with a cardiac substrate, I'm not that worried about it. Giving it in a CKD predominant subset, I don't know what my nephrology colleagues would feel. I personally do not initiate. I always follow what my colleagues would say in a CKD dominant pathology. But when there is a cardiac dominant pathology with a cardiorenal syndrome or a chronic CKD concomitant to that, till the time GFR is more than 30, it's okay with me. Not an issue at all.
Yeah, thanks, sir. We will take the opinions of Dr. Shashi. Kumar, you would like to add, and then we'll move to our.
For nephrology point of view, so I'm quite comfortable of using this ARNI in those patients, those who have GFR of more than 60, or those patients who are end-stage renal disease, having heart failure, and especially with no urine output, because I have nothing to lose. I have no GFR to lose. I have less risk of hyperkalemia. And heart failure incidence of in end-stage renal disease patient is quite high, maybe up to 60%. So I'm quite comfortable of using this molecule in my dialysis patients. But in between subsets, those patients whose GFR is between 30 to 60 and 30 to 50. So in 30 to 60, I use this molecule with monitoring. 30 to 15 is that subset where I'm really worried to use this molecule. SGLT inhibitors, as already mentioned, it's a drug of choice for a spectrum of heart failure. Even in fact, this is the class 1A recommendations for use in HFpEF patients. So I would like to use SGLT inhibitor first in those patients. But as I said, today's till date recommendation, we can use GFR up to 20, but we have studies in pipeline. And recently I saw the KI reports where they are using this molecule in end-stage renal disease patient as well as SGLT inhibitors. So in advanced renal failure, not on dialysis, I am quite worried, and I'll monitor the serum creatinine and serum potassium.
We request nephrologist view on this up to what eGFR, sir, your views, Dr. Ambedkar and Dr. George, sir.
Dr. Ambedkar first.
Yeah, as far as the ARNI is concerned, I think it's a drug which has proven its efficacy as a pillar of treatment of heart failure. So I would start with a dose of something like 25 milligram twice a day. Perhaps I would not use it in a very low GFR, but in a where there is even above 60, I don't think there is any problem. 30 to 60 also I would start. And as I said, these patients require monitoring. So probably you would call the patient to your clinic maybe once a week or twice a week. If you are sure of that follow-up, there is no harm in starting with a lower dose. Also, you go from 25 to 25, say twice a day, to 50 twice a day, and step it up as depending upon what the potassium. And I agree with Dr. George. Dr. Kriplani, you must have heard of him as a nephrologist. एक बार उन्होंने हिंदी में बताया, हार्ट अगर बचा ना हो तो किडनी गया खड्डे में. That is a little bit of a harsh statement for nephrologists, but it concurs with what you said, that even if the patient requires dialysis, you have that facility. एक बार हार्ट ने तकलीफ दिया तो फिर मुश्किल हो जाता है. Everything becomes very difficult after that. And we have all seen sudden cardiac deaths occurring in patients who are having stable renal function, and then you run a big risk. Because if you try and understand type 2 diabetes, the cardiac disease is there when the patient is diagnosed to have type 2 diabetes. So the cardiac disease is already there. So if you don't tackle it in time, it's going to lead to a lot of trouble later on.
Yeah, I like to add on that it's not just to control the the blood pressure. See, we have to prevent the progression of renal failure. That's also very important. As a nephrologist, our main duty is to prevent and we don't have many drugs in our armamentarium to prevent the progression of chronic kidney disease. And as all the panelists have mentioned, all the benefits and GFR, etc., we have to keep in mind this can help in ARNI can definitely also help in preventing the progression of renal failure also. So that's one more point I'd like to add.
Thanks, sir. Sir, expert comments from our esteemed moderator. Dr. Satish K, sir, your views on this?
Yeah, I agree with most of the views. Like regarding renoprotection with respect to ARNI, there is still some debate. So it is still not proven beyond doubt that ARNI is going to help prevent decrease of eGFRs. So that is still debatable. But rest of the things, I definitely agree with everyone.
Sir, we will take one last question from the audiences. I'll request our nephrologist, Dr. Ambekar, sir, that role of Sacubitril Valsartan in resistant hypertension. Is there any role of this molecule apart from HF? Can you highlight your views on this?
Yeah, recent studies have demonstrated that, as you know, 3 drugs, including one diuretic, is especially one MRA, would be probably helpful in treating resistant hypertension. But the recent studies have also shown that ARNIs play a very important role in the treatment, and I think it's probably one of the drugs which should now be included in the treatment of resistant hypertension. Probably, of course, some of the studies are still going on, but definitely there are more pointers that it should be used as a treatment for resistant hypertension, because especially I'm sure Dr. George will agree, sometimes in chronic kidney disease, hypertension becomes a real major issue. And in those, even with borderline creatinine, you would find that these patients have blood pressures which are very difficult to manage. Just to give you an idea, any diabetic patients with chronic kidney disease and hypertension, probably you would require 3.5 types of, and not drugs, not tablets, but 3.5 types of antihypertensives to control the blood pressure. So probably with a little bit of caution, these drugs can be used, and they should be used probably right now.
Thanks, sir. Any other expert panelists would like to add on this point about the resistant hypertension's use?
Yeah.
Yes, sir.
Yeah, resistant hypertension is very difficult to manage. Like as Dr. Ambekar sir says, like in CKD, resistant hypertension is very much there. But very often what we see in our practice, like it is most of the time it's because of non-compliance. So having ruled out non-compliance and other things, definitely CKD and ARNI in most of the trials or almost all the trials, like during the run-in phase, like most of them had withdrawn close to 10% in Paradigm and many of the other trials as well because of hypotension and other reasons. So definitely it's a good antihypertensive, but still there are no definite data regarding ARNI in resistant hypertension. If something is not controlled with other drugs, you can try it as another molecule as of now.
Thanks a lot, sir. Yeah, sir.
I have a question to the Dr. Satish. What is your take on vericiguat and treatment of anemia? Are they still one of the pillars of are they included or going to be included as the pillars of treatment of heart failure? Because as of now, everyone treats it, but what is your take on that?
So vericiguat and anemia, different thing, or as a complication of vericiguat anemia, sir? Like what you meant?
I mean, vericiguat are different. They would.
Okay. Okay.
What
Sir.
is your take on these two?
Yeah, Victoria trial, like that vericiguat trial, what you are talking of, came like maybe 3 or 4 years back. That vericiguat has not taken over the market like what ARNIs have taken over. And only indication for vericiguat in our practice is like if someone has recurrent heart failure on GDMT, EF being less than 45%. So, and recurrent hospitalization for heart failure. So this has not come into the foundational therapy, as we all know, like 4 drugs. So vericiguat is not a foundational therapy yet. So it is like, I myself have not used vericiguat so far in my practice. And anemia definitely is one of the adverse effect of vericiguat. And if we have to discuss anemia and heart failure, again, it's a very big topic, sir. Like we look at iron profile, transferrin saturations, we look at ferritin. Like if I had to like briefly tell about that, I very often look at iron deficiency in my heart failure patients without anemia. So that is like functional iron deficiency and absolute iron deficiency. Like if someone's ferritin is less than 100, so directly we take it as absolute iron deficiency, and I correct that iron with IV carboxymaltose. And if ferritin is between 100 to 300, I look at TSAT, transferrin saturation. If it is less than 20%, then that is taken as functional iron deficiency. And definitely I'm going to correct both of these. And regarding the dose, it depends on what is the baseline hemoglobin, whether I'm going to give 500 mg or 1 gram or even 1.5 grams. And definitely, like in the trials, it has shown that iron deficiency correction with IV has shown improvement in 6-minute walk distance, their quality of life and other things. So though not like with mortality, but what we always say is quality is as important as quantity with respect to life. In brief, this is my take on that.
Thanks a lot, sir. Now I request Dr. Satish K, sir, to please share your concluding remarks for tonight's wonderful cardio nephro crosstalk. Sir, please.
Yeah, thank you, Dr. Kumar. Thank you, Dr. Ambekar, sir, Dr. George, Dr. Shashi Kumar, and all my esteemed panelists here. Like it's been wonderful, like discussing this crosstalk definitely has enhanced our knowledge regarding managing chronic heart failure patients in chronic renal failure background. So definitely this is going to help in our practice. And this hyperkalemia management, it is still very difficult. And Dr. Ambekar sir mentioned, like send it to your enemy. Like if someone doesn't have enemy, you can send it to anyone. So that's how like what I can conclude. It was nice talk. Thank you all. Wonderful.
Thanks a lot, sir. Now I request our business head, Mr. Amin Roy, to give the vote of thanks. Amin, please.
Thank you very much, all the panelists for your wonderful deliberation. This was very, joyful interaction with all of you. And very first in our series where, cardiologists and nephrologists both talk kidney and the synergy between both this very, very vital organ. So wonderful program. We are going to cherish this for a long time. And thank you very much, everybody, for sparing your evening with all of us. Special thanks to our speaker, moderator Dr. Satish, speaker Dr. Shashi, both our veteran nephrologist Dr. Ambekar and Dr. Sunil George. Thank you very much, Dr. Vikas Agrawal, for being there present. We wanted to have you since long, and Dr. Anup Agrawal for your valuable insights and your comments. At JB, we are very thankful for your grateful time and for your education which you provided today to a lot of physicians who were on the other side of the screen. So thank you very much, and looking forward to have you all once again on this platform soon.
Thanks a lot, sir.
Thank you.
Bye, sir. We are ending the meeting.
Good night.
Good night, sir.
Don't forget to watch